Our goal here is to end at 1 o'clock. We have a lot of stuff to present to you, but we want this to be interactive. Okay? So the first thing we're going to talk about really is the local care team purpose. As you know, local care teams have been around for a while. For those of you who have been in the system for quite a while, it was a transfer from local coordinating council. At one point, local coordinating councils were actually entities that were put together to vote, and it was an accountability aspect to be able to make sure that when we were looking at children who needed to go to a residential treatment facility, that we were really looking at what those resources were and to make some decisions within that process. Several years ago, those regulations changed, and that really goes along with some changes that were happening in the child welfare system as far as implementing family investment team meetings and some other actual system delivery that was helping to move those processes along so that our young people were not getting caught up in those issues. So around 2017, the Children's Cabinet determined that there was a need to really look at children who were in danger of out-of-state placement. There was a very long process that happened in the amount of our children who had been who were being referred for out-of-state placement and what were some of those reasons. At one point, decisions were made that bringing together the local care team at a level of looking at out-of-state placement was one piece of it, but also really kind of going back to a more coordinated approach where we were making sure that we were coming to the table and really discussing youth that were at risk. A major change also was that families are allowed to refer themselves. It used to be that you had to have a lead agency that referred a family to the local coordinating council. And a perspective of the local care team was really giving those families the ability to come to the table and bring themselves to the table. So what we're trying to do is return or divert children and youth from preventable out-of-home and out-of-state placement through the provision of community services. The local care teams really do hold that role, and we're going to talk more about that later, of being the people that know about your own community. Every community is different. You know what the resources are within your community. So being able to be that point of access for families where they can come to the table and have a large team of people to be able to add in, have you tried this, have you tried this, have you tried this? So as of January 1, 2018, the local management boards again serve as the administrative home for the local care team. For those of you who were around when we moved from local coordinating council to local care team, there was a decision among each individual jurisdiction as to how they were going to operate their local care team. Some of them have their responsibilities among different agencies. There may be a referral to one agency and the paperwork was maintained by another agency, or contact with a parent was delegated to another agency. Who was going to hold any paperwork? What kind of paperwork would there be? Now that has all come back to the local care team coordinator. The local care team works through funding received by the local management board in order to actually be that administrative home to ensure that nothing gets dropped off in the process. Does that make sense? Again, please ask questions as you go along. So I want to make sure, because just so you all know, I have a bit of a difficulty looking behind me. So I'm reading from here. Chris is making sure that he is my on-point guide to get the slides going in the right direction. So the local care team authority, Children's Cabinet directives, local care team coordinator funding. The funding now for local care teams through the local management board really is coming from a myriad of our child-serving agencies who have made a commitment, because this process is very important to all of our child-serving agencies. So you have Department of Human Services, Department of Juvenile Services, Department of Health, and the Department of Education, who are actually money to go through the Children's Cabinet interagency fund to be able to support the securing of an administrative person to lead your local care team. That is a little different than some of the funding that comes through for programs that your local management board goes after, but this is very designated. So the very important piece of this is a very well coordinated process and a commitment by those agencies to really ensure that the roles within the local care team are covered. Sure. They are the Department of Health, Human Services, Department of Juvenile Services, Department of Health, and the Maryland State Department of Education. Local care teams are there to ensure youth with intensive needs receive comprehensive support services. So that is, making sure that we've talked about what's already been tried, what else is out in the community, how are we going out in the community and finding other resources, and one of the things we're looking at is what don't we have? Get that locally, and you all surely know that. We're looking at what does our county not have that we need. From a state perspective, we're looking at what does our state not have to be able to really fully complement the intensive and complex needs of youth that are coming through. Hi, Mary.
Hi, sorry I'm late.
No, you're fine. Welcome. Part of what we're doing is also we are looking at referrals and tracking, maintaining comprehensive resource database. We're going to talk about that more later, about the directories that you all will be looking at. Also ensuring some follow-up on services. Sometimes what we know is everybody has a great idea, you implement something, and then not always sure where the services go after that. So part of your role, as you know, and part of the directives is to follow up and know what's the end result of the decisions that were made or the discussion that happened at the table. And also facilitating a coordinated approach to services and making sure that parent involvement is happening at the local care team level. Questions about that? Anybody surprised by anything in that? Yeah. That's what we want. The role of the local care team also who can make a referral. As I've said, parents can now make a referral. Pretty much anyone can make a referral. Most referrals come from a lead agency, but we do have parents who are self-referring. And part of that is responsibility within each community to make sure that information is out there in your community to ensure that family does know that they can refer themselves, what that process looks like. We can talk about that a little bit more, but this is just an overview of that component. We want to make sure that families do recognize that there is a place that they can go just to brainstorm about what services or what something new is that can be tried. How does the local care team help? It is an avenue for people to be able to come together so that we're looking at children at risk of out-of-home and out-of-state placement, looking at complex needs, and we're looking at families who are in crisis. Many of you, I'm sure, have now had the experience of being in the situation where what a family's crisis is really defined by them. Sometimes we don't see or fully understand that crisis, but it is where the family is. And you're living and parenting or caring for a child that has a lot of needs, mental health diagnosis, developmental disabilities diagnosis, whatever those issues may be, that family can often feel as if they're in crisis all the time. So us being able to take a step back as a team and be able to look at, we really need to be where this family is at the time that they're coming to the table, at the time that they're reaching out. We also know that many of you probably also get phone calls, and maybe that family never actually reaches the table. It was crisis alleviation and the ability that they had someone who was familiar with the resources in their community who could help direct them to an area that was significant to being able to help their need. Okay. Sometimes it's just a matter of coordination of multiple agencies. We all hear terms such as multidisciplinary teams, assessment meetings, local care team meetings, different names for multi-D meetings. Often we struggle with trying to figure out what the difference is. It's just like any other aspect of a job that you're doing. You're looking at, okay, we have this one area. So often a multidisciplinary meeting is very specific to the people that are coming to that meeting. You could have a Department of Social Services multi-D meeting. It's really often, most likely, 90+% of the time, about Child Protective Service issues. You can also have a FIM meeting, a family investment meeting, that could be about children in the DSS system who are at risk of out-of-home placement, or who really have a lot of needs, and you're looking at bringing in a bunch of different people specific to that family. A local care team meeting can be very much the same. This is where you have true agency partners coming to the table, as well as parents who have experienced this system aspect of how do you negotiate through all of the systems that you may need to be involved in. Many of our families will come to the table with social services involvement, juvenile justice involvement, mental health involvement, what other involvement, educational issues. This is a true way of being able to kind of look at all of that, having some supports at the table that can really talk about what that looks like. Any questions? Role of the care team, we have put a link here, and please know, I failed to say this before, we are going to provide you with electronic copies of all of our PowerPoint as well as Heidi Rashan's PowerPoint at the end of today, okay? So you will have all of this. The Human Services Article 8-407 is one of the laws or statutes that we operate under. Really does explain, and I'm not going to read all of this to you verbatim, but it really is talking about the forum for families of children with intensive needs. Intensive needs, complex needs, families in crisis, that's the crux of what, you all know that. Those are the families coming to your table. It's all about interagency discussions. You know, it's also looking at generating referrals when they're appropriate. Training and technical assistance. We provide you with training and technical assistance, but it's also your ability within your community to make sure that everyone in your community, your role as a coordinator, your role as a local care team, is to ensure that the community is aware of the local care team. The community is aware of the ability to come to the table. And that is aspect of what you all should be working on regularly, making sure that your team is as educated as possible as to what the local resources are. To care management entities, also identifying and sharing resource development needs. What does your community need? Reaching out, working through Chris, through your community, making sure that you're bringing resources to the table. You know, oftentimes we'll find out that maybe there's a psychiatric rehabilitation program in your area, and if you don't reach out to them, if you're not familiar with their resources, sometimes we've found that those resources are also looking at in their strategic planning as to how do we branch out? What are other populations? What are other needs that could be met if we expanded our programs? Or what are some of the challenges that are happening if we don't expand? Or maybe that's a way for them to learn more about what's needed in their community to be able to develop some more creative approaches to being able to take in some of these youth or provide services for some of these youth. Rehabilitation programs are often those assistance funded. We do know, and I've been watching the numbers coming through, the amount of families that you all are working with who come through with private insurance, which clearly creates some barriers to getting some of the services that are out there in your community. But also looking at, you've heard my example before, if you reach out to different resources, I used to work for a psychiatric rehabilitation program, and we would have skill building groups for young people with medical assistance. But for every group that had 8 to 10 young people in it, we made a commitment as an agency to take in 2 private insurance youth because we could serve them in a rural community that lacked a lot of resources. Oftentimes, we don't know those types of creativity or brainstorming opportunities with our resources unless we reach out and talk to them about what the need is. Maybe they can't fulfill a need for an entire population, but maybe they could fulfill a need for 1 or 2 of your high-end youth that would meet some of their criteria. And our last true piece of that also is discussion of any request for voluntary placement agreements for a child with a developmental disability or mental illness under the family law article. So that family law article is also cited for you when you get the electronic version. Okay. Membership. Yes.
Going back to resource development, I've come across a number of resource or programs or facilities who are really eager to be part of our mandated.
Right.
How do we work around
that? Could you explain mandated core? Like
the mandated agencies that are on our list. They've got the LBA, all of these guys, DJS, these guys. But there are other community facilities and programs that are, why can't we?
So here's where there could be a difference. There is a difference when you're looking at community resources, and then you're also looking at potential vendors. Potential vendor who's coming to a table really to brainstorm with a family on current needs, and say you have different mental health services beyond your local behavioral health administrator who's at your table. We really have to be cautious about how we invite people to the table in a vendor capacity because what we don't want our young people and our families to get hung up in, how do I choose? They're here at the table, they're offering. Could you have those resources come to a local care team meeting? Oh, I didn't know. Kim was looking at me and
looking at the slide.
Could you have those resources come to a local care team meeting without family involvement so that your team can be very much educated on what those resources have to offer and what their referral process is? Yes, I would deem that as, I know some of you may laugh about whether or not you ever have any downtime in your local care team meetings, but part of your responsibility is to be aware of what your resources are. Could you have vendor agencies come in and tell you what they're doing in the community and express to you what their interests might be? But would we want that to happen while a family was sitting there coming to the table in crisis where it's kind of a market? Who's going to sell their program? So it becomes a very different level of decision making. Happens.
So, Cindy, I do have a comment. So the other thing is that the membership on the local care team is designated by that statute. So I think it's probably very difficult for the state or legislature to designate a nonprofit or a particular private entity to participate in something. So I don't see the legislature saying that the Boys and Girls Club has to be there. I think it becomes a legal issue as well.
Okay. Fair enough.
Yeah.
Right.
Is that better understood? Is that helpful? Okay. All right. So the Human Services article, we're also looking at the local agencies that attend. So you are very well versed in who your agencies are that should be there. Care teams in the past that have invited some of their partners, say Parks and Recreation, especially in rural communities. Your youth end up in Parks and Recreation programs. If you're looking at discussions about resources, I have found that those entities being able to come to the table when they're not necessarily, their staffing patterns are not necessarily looking at the needs of some of our high-end youth. But we have found that periodically the local library, the Parks and Recreation program, some of your organizations that are not selling services but are seeing many of our young people, our libraries, some of them around the state and across the country are beginning to open up special rooms just for adolescents who end up hanging out at the library. They like to access the computers, but they end up using that as a place, especially in the summer times and after school, as a place to congregate. So trying to take some control for the library of keeping those young people and giving them an area where they can talk instead of being right in the middle of all of the books or hanging out on the steps. But, you know, it's also our encouragement of don't forget those resources in your community. It's who can provide a service to a specific population, but where are your broad-banded programs that are out there that are seeing these young people anyway? Invite them to the table to talk about what your needs are, and not necessarily with a family, but again, it's a resource out there. Your local library is doing. Have them come and do a presentation about what they're doing with our young people, some of whom may be our young opportunity youth. They could be 16 to 24 who are showing up because they're not working and they're not in school. What are some of the resources? What kind of funding then can they access through some of their foundations or through some of donations or whatever happens? Sometimes we find that we've lost. Really looking at those members. Our community centers that are open, you have faith-based programs that are out there. You know, part of looking at resources and looking at the gaps is also looking at where can you build and what haven't we tapped into?
Just remembering the natural support.
Heidi said she often talks very lightly.
Right.
But looking at the natural supports, what are the natural supports in your community where young people could access or where those groups want to reach out and really talk? We're still on the role of the local care team, youth and family priority populations. We're looking at out-of-home placement risk, complex needs and crisis, access to resources, voluntary placement agreements. You guys hear that all the time. Families come to the table seeking any kind of assistance that they can get. To the table also with their own ideas on what that should look like. So it does require a lot of negotiation, a lot of listening. We're going to talk more about that a little bit later in more detail. But we also know that parents are coming to the table. Some of them have their own reasons that we can understand, and some of them have those reasons that may be a little bit more difficult for us. The fact is that if a parent is coming to the table, they perceive that there is what they need to help their child in any way possible. They've often been to many other doors before they get to the local care team. Otherwise, they're the ones that are calling you up on the phone, and it's easy to answer their question and in the right direction. But when they actually get to the table, they have probably experienced multiple venues of partners around the community. Coming for that ability to be heard and to really have people at the table talking to them, listening to them, really looking at the issues as to what helped them get to the table to be able to work with them. Again, we're going to talk very much after the 12 o'clock hour about voluntary placement and family voice, so we'll get into more of that. But voluntary placements are definitely a requirement. All voluntary placements must come to the local care team for discussion. So that is a very specific need that needs to be fulfilled. Interagency Placement Committee, as many of you know, we always invite our Interagency Placement Committee to interact with the local care team. You have two of the members here today, Sheila Phillips and Janet Furman. If you have met them before, they've to you before. I would like to hope that many of you participated in the WebEx back in June to learn more in detail about the goals of each one of those agencies and kind of the structure of them. The Children's Cabinet, effective January 1, 2018, designated the Interagency Placement Committee to serve as the state coordinating council. How many of you know what the state coordinating council was years ago? Not very many.
What is it?
Anybody want to give an idea of what it was? An idea of it?
Sure. Sometimes when parents were dissatisfied with what the local care team did, that was a resource to go to or try to get this worked out. Also, for the kids going out of state, we used to always have to just approve them at the local level, but send them up to the state coordinating committee.
Around for many years. It still is around. It's just now renamed Interagency Placement Committee. The State Coordinating Council had a much higher responsibility in approving out-of-state placements as well as residential treatment centers. Also became a little bit of a backlog. I'm not going to go into all the detail. When you look at the statutes and if you look at history about State Coordinating Council, you can surely read what all of that is about. Our Interagency Placement Committee is now taking role of the State Coordinating Council, and that are your members of Maryland Department of Education, Department of Health, Social Human Services, Juvenile Justice, Developmental Disabilities, Education. Who am I missing? It's GOC. And the role of the Interagency Placement Committee at this point is really to look at those youth being referred. We would make a referral to the Interagency Placement Committee, which we call IPC, just as we call LPT, for youth that are referred or recommended for out-of-state placement. That is not an approval process. That is looking just at a different level from the local care team at what has been done to help keep that person, that young person within their state. Again, when we're looking at just prior, in the early parts of 2017, we had some public issues with youth who died in an out-of-state placement. We had some issues with with a particular out-of-state placement facility that had several different public concerns about treatment of children in that care. And at that point, the governor actually pulled together a large committee of our child services. GOC participated and facilitated that process to look at our out-of-state placements and to really look at bringing those youth in out-of-state placement back to Maryland. We went from years and years ago, and Kim definitely has these numbers for us, but we were looking at 1,000 youth that are in out-of-state placement. Back in the around 2015 to 2017, we were really at like 200 and some youth. And DC members, where are we at now? We were at 19. That doesn't mean that we don't have some going and coming.
Still kids going out of state.
Yeah, we have kids going out of state. We're trying very hard to build those resources.
What I see is we just don't have enough capacity to serve all the children that are at risk and need RTP locally.
Yeah. We're going to talk more about that because that goes along with looking at the services and looking at Interagency Placement Committee and some of the data local care teams need to be providing. You all are aware of that, providing to the to our office and to the IPC regarding the numbers of youth that are being referred, what the reasons. So there's some data that's being captured, not some, there's data being captured to be able to look at what are our reasons. We do recognize that our highly sexualized behavior youth, we have relatively no facilities here for them. We have some medically fragile children that need out-of-state placement because we don't have the capacity or some of the specific services. We have some very aggressive behaviors in some of our youth that we do not have the facilities to be able to manage them. So we have a pretty distinct list of why we know some of our youth are going out. We just don't have enough beds in some of the facilities that we do have some of the resources for. Our IPC members, anything you would like to add to this? All right. So what we're looking at is the IPC actually is helping to look at all of those gaps in services and being able to report out on the things that we just talked about. Youth are we really talking about? And we do have youth that are going out of state. There seems to be a rumor or some misinformation that youth are not allowed to go out of state. That is absolutely not where we are. Our goal is to be able to look at why our youth are going out of state. Have we explored every opportunity for them in state? And when we can't serve them in state, what are those reasons? So that we can eventually begin, is it a matter of designating money to build more beds or to build resources, really looking at what those gaps in services are.
I have a question as a coordinator. At what point in the process do we refer a case to ICC? Is it at, because a couple of times, they've already, the process is already started. They bring the case to ICC. At that point, do we then fill out the form and then do the referral, even though the process is started, or do we try to do it before?
Well, the way that the process should be happening is when a lead agency identifies that youth who they have explored every opportunity for that youth to be in state, the lead agency will often make a direct referral to the Interagency Placement Committee. Our goal and our hope is that they have brought that youth situation to the table at the local care team, because we don't know what we don't know. Often people hear that we've said that. Unfortunately, what also happens is even if sometimes we identify a youth who needs to go out of state, we have youth who have ended up in local hospital settings. We have had youth who have been on a wait list at the residential treatment center, and families are trying to deal with them at home. Anybody add in if I'm correct, or if there's other information. So what happens when a youth is on a waiting list to get to a residential treatment center, what's happening? What services are we providing? Have we thought of everything? Have we built a web around them that is protective enough to keep them safe, to keep everyone else safe, and to be able to meet their needs while they're waiting?
We don't have that gap when a child needs an RTC level care into crisis. We don't have 24/7 care in the community. And that's the big problem.
Yeah.
That's where you get kids that and families that say, I can't do this.
Right.
And they throw their hands up, and we put everybody at risk. But we get a waiting list of this. I mean, in Baltimore, what is it? I mean, it's just incredible.
Right.
I mean, because as a local behavioral health authority, I have to sign off on all this stuff, but I have kids waiting and waiting and waiting and waiting.
And those are discussions that are happening at the Interagency Placement Committee all the time, and being able to have our group of people there who are then able to make phone calls and look at where people are and what's the realistic point.
We've lost 50 and that's why 15, 16, we lost behavioral health, we lost Good Shepherd. I mean, none of that site has been replaced. We have another one that's on hold, Jefferson. So, I mean, it's a problem.
And at times the parents are so, and the other family members are such that one woman told me yesterday, somebody's going to die before this happens, before the person gets in place.
And child welfare, they don't have to say that they're dealing with the same as we are as a local behavioral health authority. So they're running into the issues and
because we get all those calls too. So we are doing what we can to look at resource development, other solutions other than residential placements at times, and
well, at least with we don't even have emergency respite.
children with severe or significant mental health needs. We do for children with disabilities, but not significant mental health needs, and that's an issue too, you know? It does pressure.
And I just want to add, and we have no evaluation beds at all. I did accept them 11 months after a referral. Just now, I got
11?
Here.
You're
11
11,
months.
It's the same, yeah, right now.
Yes,
And they-
11 months.
Because they have
for
8 beds,
evaluation
and then, and the kids jump us, because you and I are competing for the same spot. And it's 8 beds, and we just, and I have one kid too, that has been 10 months, I saw the list, and I said, yeah. It's really sad, we just don't have the places and the capacity to serve kids.
Right. Those are the pieces of information that should be coming through your local care team towards the IPC and to our office.
And kids,
That's the kind of
kids under
information.
12, what do we have, St. Vincent Village, and that's
Right,
it. And that's the real, and we have to see younger, and I think younger, more involved, and more children, more cute, more cute.
Yes.
Yeah, we had one mother who came with a 12-year-old and said that she didn't think she was going to make it this summer, but it was in between ages.
Mm.
But,
And they have a, things that still have a long waiting list.
Definitely.
And, Candy, I mean, there are lots of conversations going on in the IPC. They're just the Department of Health had a post-acute work group that included him from the GOC, as well as people from hospitals, Shepherd Pratt, Hopkins. I mean, people were part of that and looking at some of those same issues, and it is kind of a never-ending. So for you guys to get somebody into a placement, somebody else has to take that person out of that placement, and so it's always carefully moving pieces, and they don't always align with the needs on your end, and recommendations being made, a lot of talking to it. And the more we have actual data or situations that come to the GOC or to the IPC, the more we can then go back and advocate to other people. Because if we just go to the Healthcare Commission and we looked at that at one point and say, hey, we need beds, they say you've got lots of beds, but we don't need beds. We need a special bed for a special kid.
Right. I mean, if we could build more evaluation units, I think, you know, we could keep on, we could keep it full.
Yes, but absolutely.
So should the LCT be documenting this child had there been a bed,
Yes.
would have gone to place it, instead we're trying to serve them in the community and it's not safe?
Failing.
Documenting that and forwarding it to the ITC?
To GOC.
GOC.
I can forward a lot of cases, not even going to the LCT as well, so.
How do we forward that? I mean, we're doing our scorecard, but it doesn't really ask for that.
right. It really goes to the IPC, the law says that the IPC will collect that information. You can, use the generic, IPC email address that you use to send referrals. That would be a good way to send information, especially if you might have something that would be identified. And if you're using Virtue or otherwise encrypting it, then I would say send it to that IPC email address.
Can we send it to the LCT? I mean, it's not every case comes to me, to the
Right.
LBHA, goes to the LCT. I mean, I see enough, we fill the
You
document.
can still use that email address.
Yeah. You can send directly to them, you'll get
Right. Select it, but if ultimately it goes, you're sending it to the IPC.
Okay.
It's just that a committee doesn't have, and the IPC doesn't have designated staff.
Every county did that.
Okay, so we can have that email address too.
Yeah.
It's in the application, and you should have it, it's the one that you use to send referrals or applications.
Yes.
Right on that.
So the ITC referral?
Yes, that's right there, second bullet,
Yeah, I have, okay.
isn't it? I can't really
Yes.
see it. Yeah, it's kind of hard to see.
It is, and it will be in the electronic version that you get. Actually, a link that goes to that, and it identifies the IPC email address. All right. Any other questions on that piece? All right. Talking about the referral process, clearly we just talked about the IPC, and at maryland.gov, that is the email that we're supposed to go to. when a referral comes in, it does come in through the Governor's Office for Children. We then work to schedule that with the Interagency Placement Committee. Often as well, just going back to that, the local lead agency who is actually, they're called LEAD for a reason, who has explored all opportunities for in-state placement, once they have exhausted that process, often are the ones that are completing the referral. Our hope is that that youth has definitely been at the local care team table, just to touch in and make sure that everything that's possibly been done is there. If there is an expedited reason to have a referral, then the lead agency will definitely let us know that, and we are very much committed and have expedited calls or meetings to be able to address those. They don't just sit there and wait for available meeting. We definitely, once we know that there's a reason, increase the time period on that process, we definitely do that. Okay. Go ahead.
There were meetings every Friday. Are those open to local care teams to observe, or?
There are meetings the first Friday of the month, and there are more meetings if we have referrals that come in between in that expedited process. No, we've not had local care team members who have participated in those meetings. You know, it's a level of process where a very specific function to be able to do that. But every one of you has always been told that if you have specific questions or you want your IPC to be able to come to your table, the IPC has made a commitment that they will come out. They'll go on the road to be able to be there, to be able to help in development of a conversation about, you know, what's happening at your table, to be able to explain more about their process, but also hear from you what your process is. Did I get that right, IPC?
Not that we don't want you to come, but it's not an open meeting.
Yeah, it's not.
Yeah, I'm very new, so
Let's see. We can talk more about the review process. Again, once the referral comes in, the expedited process, and then the IPC takes over as far as really looking at what's in that referral. You know, just to let you be aware, when we're looking at information in the referral, if you go in and look at it, we're asking, what resources did you contact for an in-state residential treatment facility? We want to know, really, the date you made the call or sent the referral, how much follow-up has been done, who did you actually talk to? You know, it's one thing to put down, well, I sent a referral to a specific facility, and then I never heard back from them, and I didn't make any other calls, I didn't follow up, or we really want to make sure that we're not dropping those kids in the process by just saying, I didn't get anything back.
What if we have denial letters? Because that's,
yes.
we have the denial letters from them.
Yeah. Yeah, often that's a part of it, you know. Is there a denial? Do you have it in writing? What was the reason given? And there's a checklist in the referral form if you look at that as to why was this youth denied a placement. Often it's all the reasons that we've talked about. You know, no capacity, long waiting list, but also very specific. Youth needs are far more than we serve, or there's a checklist there, a multitude of pieces. Any other questions on that process? Again, this is also a process that's through your local care team, technical assistance person, your policy analyst, that surely if you have any questions, Chris is more than willing to be able to talk to you individually about what happens in that process or what specifically your issues and concerns may be. You all are aware, the position of the local care team coordinator requires an individual who has experienced the child placement system, a clinical and or special education background, and a master's degree in a related field. You are in your positions because you met the criteria for a waiver. Maybe you have a lot of experience working in child systems, working with children with placement, but you don't have a master's degree. There was a process for your agencies to be able to hiring you into a position based on the waiver process because your resume met the criteria for being able to meet that. Any questions about that? General responsibilities, administrative functions, local care team meeting and operations, and outcome measurement. Who wants to talk about what your functions are? There's actually a bulleted list. Do you know what they are? Heidi might give you a present. It's okay. You don't fail this if you don't know. So we're looking at some real basics. Maintaining a directory of community-based based resources. Looking at, analyzing, and doing written reports, talking about sending us information, staff support to local and statewide committees. You know, that could be you coming here, that could be you attending a meeting to be able to educate on your local care team process. You're working collaboratively with diverse groups of individuals, and you're developing and presenting training modules to small and large groups. Sometimes that's a question that comes to us. And we're going to talk a little bit more about that in your performance measure piece that we're going to talk about. But when it talks about trainings, part of what we're hoping that you're doing out there, again, is making sure that you're meeting with your community agencies, that you're making sure that when you develop your brochures or flyers or whatever your social media opportunities are to be able to get your referrals out there and to make sure that everybody knows how a referral is made to the local care team, that you're also making sure that you're training your resources on the existence of the local care team and what your roles and responsibilities are there, and what some of the work is. That's also how you get yourselves out there to make sure that resources are contacting you to get more information. They're often, vendors are going to call you and say, hey, I'm available, we have room. Again, it goes back to we don't know what we don't know. So if we're not out there and trying to meet with as many people, many agencies as possible that may touch these populations that are youth and families, we're really missing out. We're missing out on that ability to be able to brainstorm and be collaborative and creative in how do you wrap some services around the family. So you want to make sure that you're inviting resources to the table, but that you're also educating your resources out there as to what happens at the table. Because we don't know how many different places our families have connected that have worked or not worked for them. We want to make sure that we're as inclusive as possible, because how else do we do the best possible job as a team? The gaps in services are, what services we actually do have, or in communicating as well with your local management board about, you know, those true gaps as well. And when opportunities for program funding come out from a variety of different sources, not just through the Children's Cabinet funding, but being a part of that community planning process. And the best way to know that is that you're out there in the community, talking to the community about what services they can provide to families, also educating them on what some of the gaps are that you are seeing at your table, and finding any willingness. Do you have any ability to expand? Do you have any funding that could be blended or graded into being able to develop something with some of their other local resources? Does that make sense?
There's a lot.
Okay.
Lift it away, very right.
All right.
Can I make, or there it is. I want to make a comment. Or a question, actually. Looking at these functions, all of us here have these responsibilities. How many of you are grant-funded part-timers? Okay, do you have enough time? What we're being asked to do? I mean, I've been at this since February, and all of a sudden I was told I'm too many hours, and I can work hard to fulfill all of these things and do them well. Just asking. Just wanted to see how many of us are in that same situation.
So are the counties that are grant funded for the part-time position, able to access grants and partner funding?
Don't know. And haven't gotten that far yet to even be bold enough to ask.
It's a good question to go back to your local community. One of the aspects is clearly that you all are in your own local setting. Your resources are different. Your funding may be different. How other grants that they have may be different. Some communities have been very creative in how they've put together their process, sharing of duties, but that really is.
Montgomery County, we've been lucky to have HHS has for 3 years. There's another person in my office who does a resource directory. That is her job. And I know for a while, maybe 9, 12 months ago, a lot of us shared resource directories online with each other. And maybe that's something we can start up and do. I don't know if that would be helpful, but a lot of the counties seem to have.
I'm way down south, St. Marie,
Well, I'm sure there's a lot of people here that
Kim, you had that.
So the funding for the local care team coordinator goes through the local management board, and they have a separate process that they go through in order to get that funding. It comes to the governor's office, or comes to the children's cabinet fund from the agencies that you mentioned earlier. So because we've only had the funding back again for 18 months now, it is a process of the jurisdictions going through and figuring out what do they need. Do they need a full-time person? Do they need a part-time person? If it's part-time, do they need a 20-hour-a-week person or a 10-hour-a-week person? So it is sort of a moving train of them figuring out, what they need. And so if you feel like maybe there's more work than is allocated in that, then that would be a conversation that you would have to go back and have with the local management board. And there may be an opportunity for them to come back to us, next year and say, hey, we thought we needed a 20-hour-a-week person, we need a 25-hour-a-week. So we understand that it's a process we're going through and trying to figure out. And everybody has something different. People have full-time people, share a person, one local management board doesn't have a person, because they're doing it as another duty at a time. So it is sort of a work in progress. So if you're feeling that if there aren't enough hours, then I would encourage you to go back and talk to your local management board. But also you can think about how you can use the collective experience of your peers around things like resource directories and other things, because maybe, you can find a way to share things, or maybe to do things a little bit easier, streamline things that maybe won't take you out.
Fair enough. Thank you.
So when you look at your PowerPoint, if we look under administrative functions, resource directory, you all have touched on that. How many of you have your own resource directory that you're working on? How many of you are using 211? Local decision as to how you do your resource directory, and again, you guys have just talked about, are there ways to share? If you're in a small county that's, usually partnered with your other counties, does it need to be 3 separate ones, or do you have 211 came and presented to you a couple of months ago? That seemed to be an excellent opportunity for you to add information in to 211 to be able to make sure that your resources are a part of that. Again, that is something that Chris can help you identify as well, but that whole piece of it, we're just saying there needs to be a resource directory because people in your community need to be able to access that, but we're not designating to you exactly how that needs to happen.
So in Allegheny County, we utilize Anversa. Anybody's heard about that? It's been really great for us because community members can get more resources, but our hospital is kind of deceased, and we have partners So I can get referrals from other agencies on people that work through their system. If anyone's interested in that information. It's pretty cool. It's like a nationwide thing. And they have their own, like the organization of AMHRSA has people who continuously update the resources for you, so that you're not having to do that.
Any other questions on that?
We have a page for, like, Anne Arundel County has a network of care.
It might be. I don't know. I'll find out.
Okay. All right. I'm going to look at outcome measurement. As you know, you have performance measures. You've already brought that up for us. So we're looking at reporting out on data on your performance measures. Why do we use performance measures? Frequency of reporting. Everyone is aware that there is a tracking component to when your due dates are for certain pieces of information. See lots of heads nodding. That's a good thing. All right. What I'm going to do is utilize Tracy and Chris to be able to talk specifically about performance measures. Your performance measures are definitely some of the calls that we're getting to are asking for some support and some clarification. You have a very specific set of performance measures. Why do you think we're trying to gather performance measures? Why are outcome measurements important?
And close some of the gaps and, you know, like big.
Absolutely. Is there any other reason? First and foremost.
For being effective.
Okay. Effective for you or for family?
Or family. Turn the curve. Right there.
All right.
I'd like to see how many kids were able to keep from being placed out of state, to keep a track on that.
Yeah. The ultimate goal is to be able to keep young people as close to home as possible. So, of course, we know the further they go outside of Maryland's lines, that's not going to be best. That really does separate them from their home family, them from their friends, their peers, their school, their relatives, this, that, and the other. So most importantly, we're trying to keep you as close to home as possible when it is and when their services that are closer to home are able to provide them with the resources that they need to be able to meet their needs. We all know, just think of yourselves, if you were removed from your home community and your family, regardless of what you may perceive as dysfunction that we may have in our own families or in our own lives or how chaotic things are, I always ask people to really stop and think about what you would feel like if you were young and vulnerable, or even our age and vulnerable, and we lose all of the things that are that we're connected to, whether or not they're healthy for us. Home is home. Being close to home, there is a level of comfort that happens. So when we are looking at young people who are at risk of going as far away from home as possible because we can't meet their needs, we want to make sure that we are doing that we possibly can to explore what's there. And that means we need to be communicating, and we need to be creative, and we need to really think out of the box with doing that. So what we're going to do is actually go through the performance measures. You know that we have 3 different sections: what and how we do, how well we do it, and is anyone better off?
So before we get to the actual performance measures, I could just talk for just a minute about the different roles that Tracy and I have, just to kind of reiterate. So, my name is Chris Mealy, and I'm your contact for a local care team medical assistance. And so when it comes to performance measures, I'm going to work with you to make sure that if there are any questions about interpreting definitions or when specific measures should be applied, or how often you report those things and to whom you report them, because those things should be directed to me. You mentioned an official tracking mechanism. If you're familiar with the scorecard, some of you may not be familiar with the scorecard, and both of those situations are okay. But for those folks who are working with the scorecard, Tracy Webb, my counterpart, is the scorecard point of contact for technical assistance. And so we have different roles where we both kind of work together to support you as you're working with performance measures. So to the piece about whether or not you're familiar with scorecard, the actual reporting is completed by the local management boards themselves. And so, in one of the earlier slides, there was this comment about tracking data, reporting data, and so the way that it's laid out in each of your jurisdictions may vary. You know, you may be the person who's tracking the data, reporting the data, putting it in a scorecard, or you may just be the person that's reporting it to someone else to put it in a scorecard. So, you know, we'll work with you if you're trying to establish those structures locally. Hopefully, you already have them. But if you don't, you know, we're here to help you create them if you need us to, and then also kind of fine-tune them to make them work better. So, Jan mentioned turn the curve, and so we could talk for the rest of the day about results-based accountability if we want to, but instead, in a nutshell, we'll say that, you know, this is a decision-making process that we use, the Governor's Office of Children, the Children's Cabinet uses to move from talk to action. So how do we actually make change in the community? And so key performance measures are modeled after the three basic layouts that results-based accountability uses to collect data. And so we talk about how much we do, what we do, and how much we do, how well we do it, and then also is anyone better off. So those are the three frameworks. And throughout the course of a fiscal year, you would measure these specific questions, each of the data points, through whatever tracking mechanism works best for you. And I've worked with different jurisdictions who are generating spreadsheets or using web-based resources. There are some folks are recording everything in a 3-ring binder and they carry it with them everywhere they go. But the most important thing is that there is a mechanism in place that's consistent and reliable in your jurisdiction that you use to track this information. So starting at most basically, you know, what or how much we do is just a count. It's a number count. And there are these 4 specific measures, and we do have a new measure for fiscal year 20. And as we go through these, I would encourage you to kind of speak up if any of these are ambiguous to you. And there are some to interpret the performance measures depending on the situation that you find yourself in. So today, when you find yourselves in those situations, please reach out to Tracy or myself at our office, and we'll support you fully. It's important that we're all kind of reporting on the same things in the same ways as much as possible. So the number of new cases, only questions that really come up there, what constitutes a new case? Number of new cases referred to the local care team. So we want to try to keep it as explanatory as possible. It's a case that has not been reviewed in any form or fashion by the local care team, it's new. The number of cases reviewed is a more comprehensive measure that could count a youth, for example, whose case is reviewed 3 times. So if you have one new case that's referred, that is one, but if that case is reviewed 3 times in the fiscal year, obviously you're going to call all 3. What an actual review is something that should be consistent within your jurisdiction. We count an emergency BPA meeting on the phone as a review. To make that decision locally and be consistent. And later by the attendance performance measure, for example. So if it's an actual review, you want to be careful about what you're designating as an actual review because you should take attendance at every review. So that's one of the questions that comes up. What is there actually a review? What is not? Do we have to have, if we just have a few key members on the phone to address one thing, is that a review or not? If it's a VPA kind of phone call, is that a review? In-person versus phone call, there are lots of questions about how you can define a review. It just be as consistent as possible. So, of the number of trainings, we could talk again about what constitutes a training, but basically, as far as the job functions of the local coordinator and then the overall local care team, the expectation is that are facilitated, that they are provided, that they're conducted, and we're very liberal about the definition of training. That includes, I say there's kind of a fine line between outreach and training. If you're attending, let's say, for example, the staff meetings of your local stakeholders, and you're bringing your brochures and your referral forms with them, you're talking to them about the local care team, but that's training stuff. Or if you're inviting those very same partners into your local care team as an administrative function, and they're telling you about their services, that will be a training received by the local care team. So however you count training, just, again, we would encourage you to have it written down as policies, procedures, and to be consistent. So,
and the one piece I will add into that is if you look at your actual performance measures for a local care team, number of local care team trainings provided. Sometimes we have people that are only going to training, you're going to a training, you sign in, you sit, you're not talking about the local care team. That's where you really need to be able to define, because your measure is actually local care team provided. Okay, we get that question. We've had it several times in the past month. So you really need to look at your performance measures and make sure that what you are tracking is what is asked for in the performance measure. Make sense to people? Mm-hmm. If you're going, to a statewide conference and you're sitting in a room, you're learning something, but you're not providing a training. If you are coming in and then you get 10 minutes on the agenda, and you are actually talking about what's happening in your community with the local care team, and you are giving them education on how to make a referral, resources that becomes something different.
So is it only trainings if someone comes into the local care team, tells us about a new resource?
Trainings you provide.
The trainings we receive count.
Do not count today. This does not.
Right, but if we have a new resource in the county and they come in to tell us what they do and what they, it's not considered, because we receive
No,
it.
because that's something you're receiving.
Right, so it's only given, not
Yes.
receiving, got it.
Things.
Okay.
We want you to get as much training as possible.
Right.
We want the team to get as much training as possible, but your performance measure is based on.
Not training provided to you.
How many you've given?
Training that you provide.
Got it.
So it's your community outreach out there, and you are talking to a group of people or a resource, you've invited, come in, like tons of families to come in and learn about the local care team.
Okay.
You're providing that training.
Anything you've given.
Okay?
and new for this fiscal year, we have the number of local care team meetings. And we added that one, and I want to thank you all who logged on to the Google spreadsheet and populated your meeting schedules for next month. That's very helpful for us. What that does is it allows us to kind of get an idea of the averages. So how many times are local care teams anticipating that they will meet, and that they will meet in a given 12-month period of time. So again, you'll need to determine what constitutes a meeting. And essentially, if you're taking attendance and you have required attendance, we should count that as a meeting, whether it's on the phone or in person. So we'll ask that each time you actually meet, that you log that as one, and report that twice a year with the other performance measures. Any questions about the how much or what we do measures?
Just wanting to go back to the training. I thought that we also had training for the team, and so you're just the outreach that we're doing in the community, not training our team members.
If you as the local care team are providing training to a resource, which could be members of your team, that can be a training. If you're providing information to them, it's the inviting resources in to train you and the team that is not counted.
And could you explain the difference between the fourth bullet and the second bullet? The second one is the ones we've actually done. Fourth bullet is what we're anticipating doing for the year.
We call a meeting, a convening, where the members are all solicited for attendance. And then, but you could review for bullet 2, you could review 2, 3, 4 cases at one meeting. It was more case specific.
So a meeting is a day, it's not children.
Right.
Got it.
Your meeting is your actual convening of the team.
Right.
How many meetings are you having?
It could be a call.
It could be a call. You count that because you're counting their attendance. Cases reviewed, you could have one meeting
And 6 kids.
and 6 cases
Right.
that day.
Right.
Is again separate from the new cases. Maybe you have, you know,
Right.
3 brand new cases that have never been counted before. You've reviewed 6 youth and you had one meeting.
Mhm.
Does that make sense?
Perfect.
Did we
Thank
break
you.
that down? Yeah.
Thank you.
So this was sort of doing crossover reviews, reviews that local care teams, will be counting those as reviews or that's.
I'm sorry, I didn't hear
So
the
if we're
first.
doing crossover use, we're gonna use local care teams to review crossover use. We haven't figured out the schedule yet, but should we be counting those crossover use reviews? Because it's not gonna be the same structure. And
I say no.
No.
Because it's not a local care team meeting.
Yes.
It's just a local care team acting as another.
Yeah.
thing.
Yeah.
But I think when they group teams, Harvard does crossover too. We said, guys said no, like, the last time.
Yeah. Right. Local care team becomes the group, even something else, like starts making widgets. Then it's just the same group of people acting in a different capacity. So I would, if it's not an official local care team convening, then no, I wouldn't count.
some of the kids are already, they've already come to local care teams, before they actually.
Right.
So, we have to take
Yeah.
Thank you.
Thank you.
For review cases,
So what we've been doing is, like, I'll have, say, if I have 4 cases heard in March, then those are new cases. But then in April, at the beginning of my April meeting, I do a follow-up of those 4 for the first half hour of the meeting. Can I count those as reviews?
It would seem to me unless you deemed the group for the specific purpose of, you know, fulfilling that would be fulfilled in a new review, that you would not. If it's an update and the parents are not invited, I mean, that's
Yeah, they're not invited.
probably the one thing that, and we could have a separate conversation about discussing those cases, even in a brief fashion without the parents present. And that would be another conversation that we would have. And we would generally, you know, recommend against that because there could be decisions or information that's exchanged there without the parents. So, but generally, no.
They're doing follow-up.
Right. Well, follow-up does exist, but it generally would occur between the meetings where you actually have, you know, review 1 and review 2. And in between the 2, that follow-up is happening to find out if the plan is executed. And then if the case does come back for review, then there could be a discussion that way.
You can do follow-up as part of the meeting.
At an actual meeting.
So some of your meetings could be is in that you're doing a new youth who's coming to the table, and then also doing an update on somebody who came to the table last.
Yeah, that's what I'm saying, we do that, like every month, it's 4 March cases, I'm gonna review them in April, right before I do my 4 April cases, like, every month I do it the same way.
Yeah, Chris and I are both like, no.
Yeah.
Okay. We don't make decisions then, we just say, okay, on our action plan,
Yeah, but if
you were
it's,
supposed to do this.
if
and
it's
that,
official LCT action, then it should be an official LCT meeting, so you should be including the parents, I mean, you shouldn't be having these conversations about kids without,
Right, because
outside the context of the LCT.
you should not be having a meeting without a parent unless you have a signed waiver from them, okay? And even though you may be reporting out, that does not preclude someone else from wanting to engage in a conversation about that reporting out. And that is where we believe that we should not be having those conversations without a parent at the table. It is, you know, you can argue that I'm just going to go down the list and report out what happened and nobody's allowed to say anything, but without a parent being at the table, the parent have the right to know what the follow, I mean.
If you're doing LCT-like work,
Yes.
outside of the umbrella of the LCT. You should bring that underneath the umbrella.
Yes. Yeah.
I have a question. If you have an LCT meeting and the parent says, I am not able to get there, but I will make myself available by telephone, can that be considered?
Absolutely, as long as the parent is on the phone and participating. If the parent says, I cannot be there, then it really is up to your local structure to make sure that you have something signed by the parent, that a case can be discussed without them, which I do not believe we should be doing. But there could be a situation that you, as an agent, you need to make sure that you're following your own policy and procedures, but we want to make sure, and we're going to get into this a little later, that we don't violate parent rights. What we don't want is discussion that is happening outside of the parent, and we all know that it happens, where the parent is not there to be able to engage in that, even if it's an uncomfortable conversation. We all know those parents come to the table where, you know, they have one opinion about something and then there are other agency members. I have facilitated local care team meetings and local coordinating council meetings in the past. What we don't want is for agencies to be talking about situations outside of a family member when the parent, even if it's an uncomfortable situation to talk about, we need to pony up and we need to be able to have those conversations with the parent at the table.
When it comes to parent attendance, the general is that there's a difference between a parent who's struggling to attend and a parent who's refusing to attend.
Yeah.
When you have that refusal, that's when you can't move forward at all, unless there's somehow officially consenting to the meeting moving on without that.
Is there another question around here?
I had a question for the review, are you just checking in with the providers from that list of who is doing what?
Like, so I do my action plan with my meetings, and send that out, and then do follow up with the parent in those 10 days or so to see if they heard from XYZ or whatever. And then at the next month meeting, we just kind of go, okay, you know, Center for Children, yes, we reached out to the family, I've got an appointment. There's no decisions being made, it's just kind of a follow-up. Like, is everyone doing what they're supposed to be doing? Right. And I was counting those as reviews, but I guess.
I don't count them as reviews, but I wanted to know, can we do that? Because sometimes the team wants to know whether or not the service started, but we're not doing any decision making, it's just giving feedback as to where things stand. About that. If you as the coordinator are going back to service providers and checking in to say, Joey was supposed to start last Friday, did he start, or how many sessions has he had in the last, that's like part of your job as the local care team. You would then you wouldn't just a review, but you would take that information back and present it to the local care team next meeting, a review.
Right.
So when you're doing that at a meeting, then you would be saying, I checked in with these people and sent out this information, have a chance to respond, and the mom has a chance to respond. So,
But the
yeah.
key is the mom or parent has to be invited.
it has to be a real meeting.
Yeah.
Yeah, you just open yourself up to having all kinds of conversations about what went wrong or what went right, but you don't have the parent at the table to be able to have that piece of it. So if there needs to be that kind of information, hopefully as a coordinator, you're going to be doing all of that either before a meeting ever happens, but that should be with a parent at the table.
So Jan was shaking her head. Is that how you handle it, or you disagree? No, I mean, that's generally how we handle it. And I'll, if it doesn't check out, sometimes we use the meeting. There's a little peer pressure there, that somebody hasn't checked out. But I will say, in checking in with parents, that there's probably about a 50-50. Parents are like, everything is going good now. I really can't take time off to come to the meeting. Go ahead and do it now. Right. So that's
Like a 5-1 5-minute meeting, like, we're only kind of just.
Right, yeah, right, but everybody, you know,
Right.
wants.
So that would be a review.
Wants to reveal, but,
I always just have me with where the parent declined to attend.
Right.
yeah, right.
Right.
But yeah,
I agree, I think it's an accountability, thing, and it's also to make it more expeditious. Okay, you said we were gonna do this now, have we? And
There's nothing like a little peer pressure at that table that people start, you know, after the first time of misstepping or dropping the ball, suddenly they.
I just haven't been inviting the families to that because it literally is like
5 minutes.
a few minutes.
Right.
Right, just make sure.
So because we have a time boundary, I think what I would do is just glean from this discussion that at the next, we should dedicate, you know, an official section of time to have maybe a 30-minute conversation about performance measures. Does everybody think that's potentially a good idea?
yeah.
Then moving on from the how much and the what we do, we can talk about how well we do it. And the week is on the week. So when we talk about how well we do it, we're actually talking about the local care team itself. So the two measures here pertain to attendance and then attendance for the mandated members and then attendance for the parents. And so when we talk about the first one, I'm careful to say that that 75% is, and I'll read it. So the number of percent of mandated local care team representatives that attend at least 75% of local care team meetings. So each of your members then should be ranked individually to ensure that they've attended at least 75% of the meetings. You would determine a percentage overall. So if you had 10 members, at least 5 of them attended, you could report that. So the number of local care team reviews where the youth parent have attended is self-explanatory. Provided that, where it becomes complicated is what constitutes attendance, and we just encourage you to be consistent about that. And the question about, phone attendance and so on. The formats where we're including the parent. Sometimes the parents' work schedules are just very difficult. Maybe they present a report in writing. It would be beautiful for you all to have. When they do that, you have a formal policy to accept that as attendance. So, plan. So, questions about attendance? And
Thank you for that clarification, because that first one there, I think we have been actually doing it by each meeting where we over 75% and we count that.
like a quorum, sure.
Percentage that happens.
If you use easier numbers, say you have, 10 members, 8 of them attended, at least 75% of the meeting, and your reporting would be 80%. That would be the way that you report the performance measure. And so we ask you to provide the numerator and the denominator to show us how you arrived at that percentage too. So in that instance, again, it was 10 overall members, 8 attended, and that's how you support your 80%.
Really just going back and reading, these are really meant to be your headline measures, but they're meant to be as clear as possible. So mandated local care team representatives that attend at least 75%. So we're looking at, maybe your Department of Human Services person has shown up, but they've only shown up 4 times, but maybe somebody else has shown up 7 times. What you want to be sure of is you're counting how many times is each one of your members, because they're mandated to attend, and then you can look at your group. Does that make sense?
We provided individual technical assistance on this issue across the where some folks are really having engagement difficulties from certain partners, and we've talked about how to handle those things diplomatically and make sure that we're familiar with everyone's constraints and how can we encourage them to get to the table. So if you're having issues with attendance, please reach out to me and we can assist you with that. Hopefully it can all be handled locally, and if not, we have our friends at the Interagency Placement Committee who can apply a little pressure. So we'll make it work, and we haven't had to do that. So, and then the better off measures, briefly, because we have one more section about best practices for local care teams that Candy can present before we take our 11:45 break.
Yep.
And then we'll pick right back up to 12. So the better off measures, the number of percent of youth referred for in-state residential placement alternatively served through community-based services. So this is a case that, a local partner is considering out-of-state placement. They very wisely bring it in front of a local care team to find out if there are any options, and lo and behold, there are. A wraparound plan is put in place, behavioral health services are turned on, and the decision at that table that day, not a vote, but the decision or the consensus is we're going to, spend 30 days, 60 days trying to keep this youth in the community. That will count as one. And that will be measured against all of the cases that are reviewed in state. The second measure here, except it makes this out-of-state. So youth comes in as an out-of-state referral type, and youth goes out in-state, just broadens it.
Are you saying all in-state RTCs have to go to the LCT? I didn't think we had to do that. No.
They're not mandated to.
Right.
No.
Because they come directly to me for, okay.
What the hope would be that if we have a youth coming out of residential treatment center in or out there, this is just a larger perspective. The hope would be, because many of us at our tables know, and especially in our agencies know, always seeing that youth have gotten the greatest discharge planning to return to their home community or to Maryland or however that looks like. So part of what we would like to see, but it's not mandated, is that what is a part of the discharge youth who's outside of their home who's returning to their community? We've recently had a couple of situations with a youth who's constantly in crisis returning to the community. They're only there 2 days. They needed an acute hospital placement, but finding out in that process that there really weren't things put into place that were available. There may have been some discussion about what was needed, but there wasn't a real place. What would be lovely is the more information that we're able to get there about the benefits of the local care team and the people that come to the local care team, is that we're also not only doing a great job of making sure we understand why kids are going out of state or trying to brainstorm on how to keep a youth in the community, also looking at the benefits of the local care team discussion on what could benefit a youth who's coming back into the community. We spend an awful lot on accountability for why is the youth going out. What happens to the family and the youth when they've had ongoing structure, when they've been in a facility that's operated in a certain way, and then they're coming back to community-based services or something? So it's not just how do we keep them from going, it's what are the benefits of the local care team discussion, the brainstorm, creative process, what are our resources that we can make sure that a youth is tapped into? Make sense?
And when you say in-state residential, it's foster care, group home, RTC?
Well, when we say in-state residential, we're talking about residential treatment.
RTC only.
Yeah.
I know, but if they're coming back and it comes to the team.
So when I get referrals from parents, I've had a lot of parents call and say, I want to request a voluntary placement for my kid. Is that do I count that as they're seeking in-state residential, or what do I count that as?
What you're going to count is when they've gone through the agency and they have requested that.
Okay.
They've done that piece of it.
Okay, so for that specific measure, they have to have a lead agency,
So,
asking for.
To me, a parent question for a VPA is not a whole lot different than calling you and asking for a psychiatric referral.
Right.
You would refer them to where they should be. In the VPA case, in the VPA instance, that should come back to you through the Department of Social Services.
Okay.
And that, at that point, you count it.
Yeah. Just because they're asking for it doesn't mean that they meet, number one, all of the
Right,
eligibility.
exactly.
It could be a term that they've heard
Yeah.
that they're saying, how do I get this?
Okay,
That's very different.
thank you.
Quick question.
First, indicate that we have a letter recommending, a letter from a clinician recommending that we be placed in. We're getting that technical, or is it just like
letter of medical necessity, CPA. So referral means that there is a letter from a clinician saying the child needs medical.
It seems like you could have that level of detail if you wanted to, but generally, I mean, you could have these options on a referral form. And what is the purpose of the review? Is it state residential placement review, out of state? Is it for community-based services? And there, that will be your starting point. But what you require to prove that, I feel like there's a little bit of decision. All right, so, and I think probably what we'll do is give Tracy just a moment to talk about reporting. And I mentioned that we'll add the performance measure discussion to the next quarterly team meeting, and we will. But the trouble is that's October 8th, which is after due. So Tracy's going to talk to you for just a minute about the actual report itself, but then between now and the due date, of course, you're available for any kind of TA.
I think the reporting is pretty much self-explanatory. We haven't had many issues, but the question that I get a lot is, should the notes be completed for LCT? And the answer is yes. So if you're missing any data, you don't have data yet, but you expect it later, that would go in the notes field. So you would add a data discussion field and you would put it there. And you're also, sorry?
With a zero.
For the better off? Yeah. For the notes field, that's for any of the measures. Better off measures, if the measure is zero, there were no cases that for that period it was a zero. And you can also use the data discussion field to explain that zero if you would like to. We do read it. So if you don't put a zero there, we don't know if you just forgot to update it. Just by doing it, we'll know your data is updated for that period.
Notes are your friends. Notes definitely can explain what's being shown up by leaving something blank. It definitely gives the ability to really be able to demonstrate what is happening at the time. Please, if there is the opportunity to put a note in, it is to your benefit to put the note in. Okay, and if you have questions about that, that's where you come back to Tracy for scorecard and Chris.
I will say that there was a bulletin that was sent out by Kim that had the FY19 end of year CPA and those data entry requirements. Those requirements also apply to LCT. So if you didn't receive that, you can send that back out.
You wouldn't have received it, it went to your local management board on point of contact, so they're ultimately responsible for doing it. So however, locally, you've worked that out. I mean, it could be that you're feeding the data up to somebody else. It could be that you're doing the data yourself, but you follow whatever your local point of contact. But the instructions went to the L&D person.
When did that go to the L&D?
A week ago, 2 weeks ago, maybe 2 weeks ago.
days,
I can
yeah.
track, but and it went delivery, so so it wasn't attached to a particular person.
All right, we are going to take a break. We're running a little bit behind, but that's okay. We are going to seriously make it up in the hour that you have left. We are going to let you do what you need to do to make yourself comfortable from now until 12 o'clock. We will start talking again right at 12 o'clock. So please don't miss anything, but again, we are going to power pack you for that last hour.
And there's a food truck outside called Very Tasty Crab House Herbs Cuisine.
Oh my goodness.
So, that's not a disclaimer.
I'll be sending out the address. Turned I have to really start it, but I want to, yeah, so I'm gonna go through it. I brought it up, I need to on my clock. I took a part of it, but, and if you have more questions, then they can, I'd like to. I was and then, sorry. No, I just like the answer questions, like it's really hard.
because I love family, and like, I don't like, I want to like say, no, you don't want to do that, and yeah, I have it really hard time. So we'll do that. Okay, people are still on the phone, probably, but, yeah, and so I have so many things I want to talk to you about that like came up that I heard and ideas and, I have two things to talk to you about. Okay. We did that at like one time. And, without having a conversation, we all going. Oh, yeah. Did you get my feedback on this? Yeah, I made a note, so I want to talk to you about that. Because I think that the way I sent it to you, there's so much more that you don't know, that's like, oh, that's why that. But did you understand where I was coming from some of it? Okay.
Only because.
Yeah. I mean, I thought it was like, I love the information, it really helped me. Yeah, I'm gonna participate, I just sent some of the you're cognizant of the amount of time that you're long. We know that private insurance actually that allows you to say, oh my gosh, Danny, I used to read paper in a row, and I don't think that's where I was like, you know, remembering what we've always been taught about anything that we do because we break down and become a legal issue. I mean, I well, and I'll work with me, like, there needs to be a way. Some of them are. Okay. Well, have an engagement tomorrow. I know. What I would, my some of it is talent and knowledge, and some of it is like the new work. So, it's going to be a long enterprise. Something for them, the memory. It might be a family we're not working on. There's data about what happened that we want to get to policy-wise. That's what the discussion about those to make sure that every document is there's a priority should be down there and how I did. And I think everything, take that information back. I'm sitting here thinking, do you really need a regular time to talk to contract? But there's no method of that. It's that needs to happen. So, like, we just like correct it. You're probably right.
I don't understand answers for secretary of
Yes.
I don't know. That's one thing I think to do.
And so that doesn't count as.
I told him, I said, and we said, celebrate the whole time, I said, members recognize him.
So, I hear a lot of that. That would be helpful.
Really neat.
Like one. What about longer than that?
They're still at control. I mean, that really does I almost say I know, do it one day. I do think there's a couple of ones, just would automatically say wrap, without a clear, what do they say? Almost think
the case.
you give a training, but those.
So there's so many other people, I don't think they're safe enough. Sarah and Mary have to have that. Sarah used to say stuff right away.
I told you that last week. And I think we're studying it. That's up to you.
Yeah. I remember seeing
I
got the letter
all the
and I
think one reason she's going. She was on the phone with Callie one day, after being on the phone with me.
I never got a letter.
I don't know if it's, oh my gosh. I just don't know. I have to look at it. She's going, we are.
Yeah, okay.
She went on. She made some comments that were concerning to what we told her husband regarding mom.
I can probably dig up a whole
mental health
letter and
status.
edit it, but then
And I think that's when Jeff went out.
Yeah, I'm fairly certain.
Okay. Kind of vaguely remember that.
The frustrating thing for me, what I do agree is they have no opportunity for these new contracts without an extra penny. To me, that's like, look, we can give to it, because now, but we can add up there for, no one's fault. I think it's the type of well, but they are contracted, I mean, the other choice is that there, why, that's, you know.
Right, that's what you've done before. It's still a vendor. I think
Yeah. I just think that, I mean, there's some people, I like to relax, put those in your mouth, repeal, she sits on her phone and eat her Chick-fil-A, and then you come in, so sweet, she would put every family, Diane would put every family in the right, she could. That's what it said. So, but then, we're still going to, if I get, for 850 now, it's some huge. But if you need somebody, you know, it's like some of the
There you go, you can get one. You always. Okay. Yeah, that's on the more order tomatoes.
Oh my gosh, that sounds great.
There's just a, yeah.
Yeah. Oh, you don't like those bags?
So thank you.
Yeah, I'm not local. I like everything, yeah.
a little smattering of it is okay, but when they like, 4 times.
Oh, yeah.
Although I'm very proud of myself, I like doing this now.
Okay.
My mom,
What time do they stay open until? Like partially? Okay.
You're gonna hit it after.
Yeah, I'm taking off after, so maybe that'll like put me to sleep. I'll take a nap.
No, they've been pretty good. We have food trucks out here. There's really not a whole lot. So they figured out that they can, it's like 300 people in this building.
Yeah.
So they come and sell out, and then they leave. That's the only thing that I sold out.
Yeah, they've been doing that at our complex too, because it's a little bit further to get up Stony River, and so they're like, if we come here, all the nonprofits, everybody's here. So DSS just moved, so like we can get everybody. They're gonna come once a week in Columbus, and they have like a calendar where there were so many trucks fighting for those to be there. So now they don't show up like on Tuesdays, which is the one day that I'm on the Eastern Shore and work in Columbus. Yeah. Now they're not dependable. We had a deli in our building that closed. So you hope the food truck will be there. You like wonder, and then you get no food truck showed up today.
So you work on the Eastern Shore part of NCS? My mom is in Comico. Her name's Wanda Chancellor. She's on the DJ.
Your mom's Wanda? Works for me.
Oh, okay. I wasn't sure. I was like, maybe you know her. Okay. Yep, that's my mom.
Okay, that's great.
Yeah. I look probably just like her. So it's like nice people are like, oh, that's her.
Yeah. Very trouble.
Yeah. Salisbury.
And that's big on the Eastern Shore. Salisbury.
Well, like, I'll see, something just on the news or whatever, and then find out that I'm randomly related to them through marriage. And I'm like, let me rethink this. It's like, I'm related to everyone in there, apparently.
Remember that. Because you're going to get a prize for a little bit if anybody can tell me a good story about my team.
Oh, I don't count. I was like, wait, I have amazing stories. I had Sharon sharing.
Oh, Chrissy. Not Christina. I have, I have 4 Chrissys in the state, and they're all amazing. But yeah, Chrissy, not Christina. So we have, because we broke them all up, we had to make sure we had Chrissy, this is like Comico, Christina is in Southern Maryland, Christy is in Western Maryland, and then I have Chris in Baltimore City. So I had to break them down so I could come apart, but I know that Christy goes by Christina to most people. Thank you. What did they have good out there?
That's not what I thought it was when you said it.
I know, I thought it
No, it's okay. I told myself it was my treat, so I'm taking off after this, and I'm like, sounds like a nap. Okay.
That's why I did the 2-year basis like that. I thought that was, that's the year
can't have that.
Then they're vendors, right? Here's the thing. But I know they are going to be. How do you guys work
Okay. Yeah, that's yeah. Well, that's fun.
And I'd like to be on there.
And those guys, I reckon,
We plan to say, now you're gonna air
I can. I'll remind you.
I hope I've got one line item then on the budget to get to that. Essentially, the vote correct.
You might have to read.
All right, are we ready?
We're ready.
I would.
Okay. Anybody try the food truck? Yes. All right, it looks good. I was looking. Thank you. Okay, I promised we were gonna get started. Some of this, we're just gonna move through. It's in your PowerPoint. Heidi, Rashawn, and Chris, and well, I lost Tracy, I think, but we're all gonna kind of work on this together. You all know how to operate your meetings. It's just a reminder sometimes. You know, how to keep your team together, and the significance. When we've had our LCT coordinator meetings, on a quarterly basis, some of these things have come up, some of them have come up in just basic individual technical assistance opportunities. Most importantly, and because we not only have child serving agency members at the table, but we also have parents at the table, and we have peer support or parent advocates coming to the table, make sure that we're always reminding that there is, that every perspective at the table counts. You don't want to discount any perspective. You know, one of the pieces in goals-based accountability, hopefully some of you will be able to access that if you've not already had it. There's this whole piece at the end of it about, you know, coming up with one wild idea in the end. So when I talk about creating, you know, being creative, brainstorming, that means that we're willing to throw things out at the table that some people may laugh at, or some people may say, oh, we could never do that. But how many good ideas ever came out of being able to come up with an idea that somebody just threw out on the table? So, you know, really looking at every perspective at the table counts. Each viewpoint is equal to every other member. You know, we can have family members, paraprofessionals at the table. They're there for a reason. And it's a way that we learn from each other, to be able to make sure that we're going through and that whatever someone represents at the table is respected, whether or not we agree with it. But we want every individual idea to come out at the table, the thoughts the feeling. Families come through crisis, they're scared, they're hurt, they've lost trust, and sometimes through reasons that we don't quite understand. Perspective matters. Every person's perspective at the table should matter. We don't want to shut people down from feeling comfortable to actually talk about what's going on. It also means sometimes that we have to have the uncomfortable conversation. We know agencies where the parent has either not been compliant or been perceived as not being compliant. We also, in our own lives and professional careers and our own existence, know sometimes we've gotten great customer service and sometimes we haven't. And all of that really kind of puts together how people come into how some people look at their situation. Trust is a huge issue. Which also comes down to team members committing to respecting the family's voice and their vision. You all have a lot more experience and education and your work and life experience in working through systems. Some families do. This may be the first time a family is at the table. It may be the 27th time a family is at the table. You may have known them through a wide array of services that you have provided in changing careers or whatever and being in that whole system approach. Every time a family is connected with a resource has really impacted how they perceive the resource and how they perceive the help of that resource. So it's important to make sure that we are always respecting their voice. We may not agree with it. They may have been a pain in the neck at some point, just like we have. We all have those experiences. We all have a good day. We all have a bad day. The important piece is that we do not lose sight of the fact that experience matters to where they are right now. Some of our family members are going to come with mental health diagnoses of their own. They are going to come with needing maybe some form of assessment that they've never gotten. We don't know what we don't know, but what we do know is everybody sitting at the table should have the ability to talk about what's important to them, what they think that they need, what they've seen in this, and what their experience is. Does that make sense? Facilitation, strengthening your team, cross-training. This is where you've heard us say before. You know, if you ever have downtime or if you can make the time clear about what your roles are at the table, that you know what the services are that your sister or brother agency sitting at the table is, make sure that you understand what they can do and what they can't do so that we're not getting upset at the table when we think, well, that agency should do this, why aren't they doing that, when really that's not within their statute. It's not within their ability to do that. Really getting to know each other, that doesn't mean that you have to be out at lunch or happy hour or anything like that, but you really, it's a matter of knowing who that person is and being able to talk to them, ask questions of them, know the members of your team, know what exactly it is that they do, other than just show up at your table. You know, working within the local care teams to promote a family responsive system that goes along with everything that we've talked about. You know, being able to promote an environment family can verbalize or express their frustration, where maybe they can talk about what has gone right and what has gone wrong for them. Sometimes it's hard for us to hear as people representing an agency, but really being able to make sure that we're having those conversations, that we're giving that ability to get it all out there, because that's what creates the challenges and the barriers. You know, we're just talking over top of each other and we're not inclusive and we're not really realizing that they have gotten service 7 times and just kept getting the same. For those of you who are familiar with behavioral health or mental health therapy, there's a huge difference between experiential therapies and talk therapy. Talk therapy, where you just go in and you talk back and forth, may not always be what someone needs to be able to move forward. Maybe art therapy, maybe music therapy, maybe...
Or different stages of change in their mind.
Yeah.
I mean, there could be one puzzle piece that makes a difference this time.
You know, we're always learning and embracing, and if we feel that we are able to do that, there's one sentence that maybe has been said to you 10 times and all of a sudden you get it. So that with results-based accountability, some of us have had to sit back and admit, I've now done it like 7 times. I finally think I've gotten 90% of it. You know, how many times have you gone to a training and thought, oh, okay. And then you go to the same training and it's like, oh, light bulb went off this time. We've talked about this, now it matters. Making sure that you're familiar with your resources. We have gone over that many, many times. It's very important to your roles as every team member to know what your resources are and be able to communicate about them and bring them to the table as appropriate. Learn about them. Credible on the team and have a credible role model to say, and be a credible role model to say. Again, that goes to, you know, so what if a parent is saying to social services multiple times and they don't help me? Well, as we've all worked with someone that we thought they should do the job a little differently than what they do, that may have been a family that experienced the same thing. Not dwelling on social services whatsoever. It's my world.
Or it could be the family asked for the exact words, so it's perceived as, oh, we don't have that. But
right. Right. Understanding the laws related to local care teams, I would fully recommend up the statutes that we list in here, that you make sure that you understand the requirements. The requirement for Interagency Placement Committee. Make sure that you understand each other's roles. Make sure that you fully understand, and we're going to talk about that in a minute, voluntary placement. There's actually a policy as to what your role is in that, as well as your directives that you have to review, or discuss, not review, but discuss voluntary placement. And inform state and local decision makers to ensure family-friendly systems, services, and supports are effective and that they're family-driven. Seeing them at their basic levels. You are seeing them as a team, listening to them. It is important that when you gather information from them, that if there is a problem or a concern, that you actually are able to talk about what that is, whether it be reporting information back to the Interagency Placement Committee, reporting information to GOC, being able to have a comfortable conversation with your local agency that, you know, maybe you're hearing the same thing over and over again. It doesn't mean that you become the service police. It does mean, though, that you're gathering information that maybe nobody else is able to gather in the format that you're getting it. Looking at making the process easier by providing information, you want to make sure that everyone is clear about what the purpose of the meeting is. You know, the family needs to understand what the purpose of the meeting is. They need to know that this should be a comfortable place and that people are going to have different opinions, but this is where we put it out there. You should have a clear process of the discussion. It should not be all over the place. This is where I say, times have you been in a meeting where someone comes in and the only thing they ever do is talk about acronyms? DSS, DJS, IDEA,
and the LPT, and you go to the TCM, and you got to get a PCO.
One practice you want to make sure of, especially as a coordinator or in making sure that whoever is facilitating your meeting, that you're paying attention to how often that's happening, and look at your family member. Because if they don't understand what you're talking about, they are often the people that they think has full authority over everything that happens, and that they are this little tiny component when they should be an equal person sitting at the table. They have this child, they care for this child, they love this child. They may not be perfect as a parent any more than any of us may be perfect as parents, or aunts, uncles, grandparents, whatever it is, they have an equal role.
And when they're sitting in front of you, they're sitting in front of you at their most vulnerable time, most emotional time, and not at their most.
All right. So we're going to skip through some of these. Most importantly, it all goes back to listening. It all goes back to making sure that we're paying attention, that we're having eye contact, that we're being clear, talking and using terms without making sure the family knows what they are. Okay? That we are looking at body language when someone's uncomfortable. We're paying attention to when people are angry. And good listening is all about, not interrupting a parent when they are trying to tell you how they're feeling. Yes, there is redirection that happens, but, pay attention to even if it's designating one person in the team who's specific, watching body language, or have them sit next to the person that they're going to get the most comfort out of, okay? The other piece about the facilitation before we move into Heidi's presentation is really parental rights. We've touched on that a little bit, and that really does go back to, especially when you're talking about voluntary placements, if the parent can't be there, you need a 10-day waiver notice. You need to not be having conversations without the parent at the table. We should be talking about families. We should be talking with families. Every right to talk about what their experience is, what they feel that they need, what they're asking for, what they think is in the best interest of their child. Talking about them doesn't get the job. It's also an avenue where maybe they've had agencies that have had bad experiences with the family, but this is not an avenue to talk about a family. This is meant to be working with the family. Cannot stress that enough. We should not be having conversations about children with families without them being present. Children don't need to be at the table, but definitely you need the parents to be at the table so that everybody has an equal say. And parents have rights. They have every ability. They need to know. And we should be having our meetings in a way that's conducive for them to be able to be there. If you're willing to accept a call as team members, being able to set up a schedule or do an expedited process, you should count the parents on the phone as well. We don't know if they're in a hospital with their child, if they're sitting with a sick parent, or they're working and they're going to lose their job. We need to make sure that we make that a priority. Okay? I know I went through that very quickly. Believe me, I'm more than willing to talk to people about any of that. You all know how to run a good meeting. It's just, let's not forget the family perspective, which brings us to Heidi Rashan, who's the program director of Maryland Coalition of Families. And in this process, we are also going to talk about the differences perceived between peer support and parent advocate. Statute defines parent advocate. The mandates for local care teams is that we have a parent or parent advocate at the table. A little bit of conversation about maybe the difference between peer support and a parent advocate.
I'm going to try to recognize time, so push me along, ask questions. I'm going to try to get what I think you guys know and get, but know that if you don't get something, another point, I'm always willing to talk to every LCT. Foremost, I'm a parent, so I have 3 boys. 3 of those are mine. One of mine has behavioral health challenges that he's had since he was 5. He's 25, 24, seems like he's 44, drives me still to this day. 2 other of those boys also have had in and out of hospitalization still to this day, even in their 20s. So I actually had a picture of another kid I just saw on the internet. My last presentation, somebody said, that child doesn't look anything like you. And it was a kid that had crazy hair, and they were like eating fruit, and I said, oh, I guess I need to put a picture that actually is mine, because people thought the other kid was mine. So just a little bit of my experience. I've been the person at that table that everybody has said, oh my gosh, no wonder that kid is like that. That mom is sitting at the end of the table, she's crying, she's got snot on the table, she's a mess. Well, the next day, I'm sitting at the table with another parent, completely respected. It's really hard when it's your own, and when you're in that situation, you do not see things clearly. You have a completely different lens. The one thing I want everybody to understand, when you see the parents, they're not at their best. And sometimes, you know what, there are needs, and I've heard people say, well, that's what's wrong with that kid. That mom just needs to step back. Maybe that is what that parent needs to hear. It might not be at that meeting, and it might be something they learn along the way. That's really the need of that family. That's one of the needs. You throw that in the box of something that, you know, might need to be addressed at some point. You still move forward with trying to figure out what the step is for that family, regardless of whose fault it is or what the reason is at that point. And maybe some people say, well, they're just going to be here again next year. Well, maybe and maybe not. Sometimes that happens. And even if it is, it's that family's life and that child's life that is important. And that's why we're all here. So we've talked a lot about this. I can talk about this till I'm blue in the face. You have every feeling every day in dealing with kids. And so you constantly feel like you're a blender. Like one day, you know, you feel like it's smooth, and then all of a sudden something happens, and it's like somebody pushed the button, and things are swirling around, and you're trying to grab to some sense of sanity, some sense of stability, to try to put things together. You don't know what the next phone call is going to bring. Going to the LCT can be really, really scary. I actually am one of the people. I sat on 5 LCCs back in the day when they were LCCs at one time and on the Eastern Shore. So I am a huge champion of CTs and what they represent and bringing families to the table, because I've seen amazing things happen. I've seen families get out of really tough situations. I've seen some families that seem like a revolving door at the LCT, and that's okay because it kept them still in a stable place where maybe the child didn't, and they out of state. Sometimes they did, but sometimes they didn't. They still kept coming through, but it kept that family together and kept that family safe by coming back and saying, okay, what do you have now? What do you have now? I believe that the earlier family can get to you guys to find out what's there, better outcomes for the family. Sometimes I've heard people say, well, they don't need to go to the LCT, it's not that serious. But how many times I've met a family that has an RTC recommendation that says somebody told me about that earlier, I wouldn't be here. And you have that opportunity to stop that family from going that far along, take it. Like that can really save somebody's life. Skipping on you, Chris, I know you're trying to keep up with me. So I'm going to do all of the feelings. You're angry at everybody. I can't tell you how many times I've been angry, sad, fearful, all of it looks the same. So when somebody looks at me, I don't always look like the best parent. So I think you guys get what it feels like to be the parent. So I want to talk a little about peer support.
We're going to get a copy of the presentation
I'm going to get
as well.
Thank you.
And the ability to reach out to Heidi at any point with pieces that are in her.
So I'll know if you guys want to learn how to do something, your diagnosis, you want to go talk to people that know how to do that or have had that diagnosis. And it's basically the same thing. Talking to a parent that has been there really alleviates that stress. It allows you to not feel alone. It reduces your stigma. There's so many benefits of talking to somebody that's been there. I'm sure you can think of a time in your life when that happened. Staff have gone through and still continue to have crisis and have things that happen. It's sometimes impossible to get out of it quickly. But they've also been trained to be able to help support other parents. They've become credible role models to help other families see that there is light. There is a light at the end of the tunnel. And they use that experience, and they're trained to take pieces of their experience to be able to help relate to families, to be able to build that trust and that relationship. Ideally, we would love to be with all of your families before they come to your table so that they know what to expect, how to tell their story to you guys in a way that's not gambling, which I'm sure some of you heard, like you're like, oh gosh, we're running out of time. We try to help them prepare that story so they give you the important pieces of what they need. surprises, Candy mentioned. Anybody got a good story that knows about some peer support stories from the LCT to tell me an surprise for you, if you can tell me something?
So, like Candy mentioned, sometimes we work with agencies and other capacities, and that's what influenced me. I did 1959, and I had the privilege of working with a few of your staff members, and then when I came over to this role, I'm still working with them, but they're like, I refer families. I know that Sherry Allen is very passionate about what she does. She follows up probably more than she's supposed to.
Yes, she probably does.
But she has a that I put in my bio that I had to create yesterday for my position was something that I got from the Sherry when she said sometimes the unimaginable becomes imaginable if we push ourselves. You know, sometimes, like she's had experiences with her child. Sometimes she's had experiences with her child. She's transparent, and she tells her families, I'm not going to do everything, but I can tell you just enough so that you can make, you know, your story of success. So, I have more, but I'll
I don't know how to.
Nicole Cooney, from Sherry, Howard and Charles, I believe. Wow, just yesterday we had a parent who was, she's lost all hope. And got an email this morning saying Nicole has offered to do a training to help how it feels to be a parent. She is a parent of someone with disabilities. It's a very and also, of course, reached out to the family. First time they came in, she asked, give me a map of the room so we can know where everybody's sitting. Even that little bit of information makes me. So she's a queen.
Nicole is amazing. Nicole is amazing. Anybody else? Can you name your MCF person in your region? You are not allowed.
No, I'm gonna say, I'm thinking Cindy Kirk is amazing. She takes on our LCT, and we've just had the best experience with our families, with her, and yeah.
Okay.
How many of you have a parent that is not with MCF, but you have a parent advocate or some other? Okay. Because this isn't all about.
Yeah, and that's what I was going to say that, yeah.
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 It is simply, Heidi represents the majority of, when we have peer support, people at the table, but we don't want you to believe that this is all
So I
about.
promote all peer support. I don't care who's doing it.
Right.
And so, yeah, I guess I should have qualified that. I've been with MCF for 20 years, so I'm used to saying MCF, but honestly, I don't peer support in general. And I did want to switch to the next one. I also want to say that I mentioned that family advocate is a term that's used. And actually, when I started with MCF, that was my title. I was a family advocate. Then I became a family navigator, and then we changed the title. Peer support is really the method. So I use being a peer capacity to advocate for families, navigate families. The other things that we do that don't always fit into that title, I'm informing families, I'm educating families, I'm empowering them, I'm mentoring them, I'm supporting them, listening, guiding them, navigating them. There's so many things that we do that don't fit that title. So I think advocate captures the umbrella of it. And actually, I think they probably just used old language that came from a long time ago, and it just never gravitated to become something different. But we actually started using the term family peer support specialist because we felt like it was the most clear about what we do. There's lots of services. Just as every family is different, we're doing something different with every family that we meet. Some of them we're not educating. They have the information, but they just maybe need some emotional support. We're doing lots of different things with every family, so the specialist part of this helps, part of that title helps us figure out what that is.
Yeah, and to add in, parent advocate, some of you may be familiar, there's always this thing about family navigation and systems navigation. A component of family navigation is usually delivered by a family member who has system experience. Systems navigator is someone who is very much like you. They're knowledgeable about the resources. They have learned through their skill building how to navigate a system. That for parent advocate can be someone with lived experience, or they could be someone who has been educated, gone through training processes to be able to be a paid employee who is advocating for the rights of a parent or a skill set of a parent, or to get some resources. Whereas a family peer support specialist or peer support is definitely in that continuum of a family member, a caregiver, a parent who has full experience in knowing what it is to be in the position of that other family member who is sitting next to try to work through being the parent of a child with very special, very complex needs, and in a situation of crisis. So if you look at it that way, we're delivering the same kind of job. Peer, the family peer component of that is always going to be someone who has life experience, parenting or caring for a child that has been through all of the things that these youth that are coming to your table are about.
I credit Maryland. So Maryland has a contract with NCF to provide support to the LCTs when a school kind of got slid in the end of our contract because we really felt passionate about it, is that we have staff that can sit on the LCTs when we're asked to do that. Some areas our capacity is limited to go to everyone versus some of them to when parents need us. We believe if we had our way, we would be at all of them because I think that's most effective to be a part of the full team. And I think believes in the system of care and the fact that peer support is important and it really matters. I love the fact that they've asked us to be that role. However, I respect every locality to determine how they want to do that. So, some of the unique benefits are, one of the main things is you guys can say to a family the same thing over and over again, and they may not hear you if you don't see you as a credible role model to them. Sometimes say those things, the very exact same words to them, and it clicks because we are able to put it in a little bit of a spin on it, but it really makes sense to them as a family member going to get out of that service or what it is they're saying and how it's being perceived. If maybe they're like, oh, well, that's not what I meant at all, we're able sometimes, because we can see both sides of it almost. I should have had mediator to that on the list. Sometimes we are mediators. To be able to say, oh, I get that. So when we're able to build that, we're able to be able to affect their engagement in the services they're getting. Choose and understand, oh, I'm just not going to take all of these services because DSS or the school said I need them. Let's talk about which ones you really need and which ones are going to be valuable to you, because you can throw all those services you want at somebody, but if it's not a service that they need, they find value in, A, they may not participate, which then is going to get them the title of non-compliant. It's just not what they need out of it. So we want to be able to help them determine by navigating what services they need and which services they really don't need to take participation in. So the other benefits are we're reducing that isolation. So many families report to us, I'm not alone anymore, like, I get it, I'm not myself. And always blaming themselves. We're able to help them step out of that and learn to take care of themselves, learn to understand how to advocate for themselves in an effective way, and then to be able to collaborate with other professionals. One of the things that I take pride the most is making sure that all of my staff are seen as partners and not as the term advocate, because a lot of times when people hear the word advocate, they go, oh, no, not one of those people that's going to come in and bully everybody. Mm-hmm. That is absolutely not what I want any of my staff to do. It's what I don't believe, and I don't believe that works. Parents to be partners with all of you to help improve their outcomes. I think we talked a lot about seeing the family first and not their needs, not just their needs. being able to understand what they really find valuable to them, being honest, upfront, non-judgmental, and teaching them versus just serving them, listening to them instead of, as soon as they come in and say, oh, I've got this, throwing, you know, oh, you just need this program or this program. Well, maybe not. Let's listen to hear them out first. All of our peer support specialists have lived experience. They go through like 40 hours of training on all kinds of things, including LCTs, being listeners, engagement, systems of care, all of those things. So, click on just a few things that some of the families have talked about us. My SSF was more beneficial to me than my family and friends because she's not judgmental and always understands the difficulties in and she gave us realistic solutions. Sometimes professionals suggest what's good on paper, but it isn't realistic. And that's a little bit what I talked about, was really talking about, this is what this service is. We had a family, actually it was Nicole, who had a family that, she had a list of services like this long. And Nicole, the mom wasn't showing up at a lot of them. She was homeless and like sofa serving. She had family members that she would alternate living with every week. She wasn't showing up a lot of the that she was given because we found out she didn't understand what each one of them meant. I think she had FFT and FST, like she had MST, she had all these services, she didn't know what they meant. So Nicole sat down with her and created a calendar. First of all, things she did was she did a map of this is what this service is, and this is what the benefit to you is going to be of the service that she had. Then she helped the mom decide which ones do you really need at this point in your life. The mom picked which ones she wants. She did a calendar for her that mapped out where she was living that week, who was going to drive her to each one of those appointments, and really helped her understand something that she could refer to, all of the people that she needed to connect to because she was confused about who was going to show up that day. And the improvement in that family was really important. Like the outcomes really were able to be achieved because mom was participating, the family was getting the therapy that they needed, not just running around trying to figure out which service they're supposed to go to because somebody said they have to. So in some counties where we have specific contracts, we actually serve as the family advocate on LCT. I believe you guys, region, Queen Anne's County, City, Washington County, counties that have contracted with us directly to pay for family peer support in their community. So those counties get priority. The other things that we're contracted to do are the TCM plus families. The families that get referred for care coordination are our next priority population of families that we support. So Comico County gets a lot of our staff because they have the highest number in TCM that's referring families to us, like by 80% higher than every other county.
Wow.
It's a huge amount. So what that means, though, is because we have one state contract to provide and its capacity, it means that other counties that don't have as much TCM population may not have the amount of staff that can go to all of your LCT meetings. So we try to balance it based on where we can attend. Any family that we're working with that invites us will go to an LCT as well. About that, you can flip through that. We covered the slide. We actually have a region. We have 5 regions. Each region has its own supervisor that supervises each one of those teams. Anybody that has questions who their person is can always call me. Kind of our mission, which I've talked a lot about, is really to help families get to where they need to be. We actually have other contracts in the state where, so we actually have FPSSs that work with family members that have substance use issues. It's any family member. So for mental health right now, it's parents that have children. For substance use issues, it's any loved one, and problem gambling is loved one. You can always make referrals to us throughout the state for any of those families as well. Might be another resource for you to add to your resource guide. And then we take all of the experiences that we have to be able to advocate for families as a whole across the state. We are constantly talking at this about things that are working and what's not working to help improve them based on their experience with families. We have a centralized intake now, which is actually really new to us this year. So when somebody calls us, one person that takes all of their information, including an empowerment survey, which kind of measures where they are in terms of knowing where resources are, knowing how to access resources, how do they handle a crisis, do they know how to take care of themselves, and how their child or their loved one is. We have Spanish and English capacity. However, my Spanish speaking, I've not publicized it. She's really, really overwhelmed. So if anybody knows of any grant funding for some Spanish speaking, we really, really need to expand that because I'm at capacity with that. This is how you can access peer support. You can also contact the FPSs directly. They will take intakes or they will refer them to intake specialists. And remember that families don't give up. So honor their, sometimes you may think they're going to give up, but they really don't. Honor their courage and strength to go on every day. You can contact me. And I rushed really through that at the time, so I could leave time for BPA. Thank you so much. Questions that I didn't answer or
I'm just blown away by your program.
Thank you. I am too. I love it. And I love talking about LCTs and doing that.
All right. We are going to have time for questions in the end, and then Heidi and I will both be here, a little afterwards. But we are, very importantly, we're going to talk about voluntary placement agreements. As we have discussed already, voluntary placement agreements are one of the mandated components for the local care team. All voluntary placement agreement referrals must come in front of the local care team. It is in statute. That's why it's very important for you all to know about the Human Services Article 406 and 407. You also should be aware that there is a Social Services Administration Child Welfare Policy. We have identified that for you in the PowerPoint, but it is number 15-22. There are mandates within that statute. We've also copied that so that it will be part of your digital opportunity to look at that. I would strongly suggest that you all get to know that very comfortably, because that tells you what is supposed to happen at the table. When we talk about voluntary placement agreements, we're really talking about discussion. Moving away from reviewing, we're talking about discussion. Your purpose at the table is to look at social resources that could be available for that family outside of a voluntary placement agreement. The most important part that I have to say to you today about voluntary placement agreements is that local care team approval is not, big not, needed to enter into a voluntary placement agreement. They are not coming to your table for you to approve or deny. Chris and I, within the past month or about a month ago, presented LCT information at the Voluntary Placement Agreement Summit hosted by Social Services Administration. And we were there with the voluntary placement agreement workers assigned to cover all of their VPAs in their community. So we were there to talk about the process. I will tell you that it was interesting to us the amount of counties that said that their LCT was attempting to approve or deny voluntary placement agreements. To make sure that we are giving you the policy information for you to research, that is your responsibility, to know what your pieces are, but that your approval is not necessary. What is important is that the discussion is happening to ensure that all of those resources that you have available locally are being attempted or have been discussed before a family enters into a voluntary placement agreement. That's the purpose. It's about resources. It's not about approval. We had 1 or 2 counties that said, oh, we're having a difficult time getting through this process because they want to deny it, and we have to move forward. You have heard us, many of you have heard us in the past. We will continue to say we are not an approving entity. Local care team is not about approving. It is about a discussion about have we gone through as many resources as possible, what's available, do we know all of the resources, what has worked and what hasn't. But we will never hold up a voluntary placement agreement because we're never going to approve or deny it. We're going to discuss it, and we are going to make sure that everybody who has something to say is well heard. We're going to ensure that the family, that we are part of the process to ensure that the family fully understands. A lot of the times there's some negativity about, you know, well, the parent's never going to agree to that because they're going to have to pay child support. Okay. Part of our role is to make sure that we work through that and that there are no secret caveats. It is a DSS form process. It is a systems process. That should be a part of what the DSS workers are talking to the family about. But we also want to talk about the benefits, and it's also helpful if you have peer support, family peer support specialist, or a parent advocate, or a parent at the table to be able to help that parent understand what some of the benefits will be, how some of the stress reducers could be, how some of that works out, what's the reality of what that looks like. Not an approving entity. How many people thought that we were supposed to approve or deny? And it's okay. We did. That's what we're doing this training for. Okay?
I mean, I feel like approving and denying is the wrong word, but we're still helping families. But say, like, as an LCT, we feel like sometimes families come to us and they haven't done anything else except they say we want a VPA. We're not, we don't approve that, but we give them other options. That voluntary placement agreement is going to continue regardless of our involvement. Is that what you're saying? Unless the family says we change our mind.
Yes, absolutely. The unfortunate component is that we do have, whether they're using the wrong words or not, we have perceptions out there that the local care team believes that their role is to approve it or deny it. One thing, because you're pretty much agreeing with what's come forward in the referral, but when we start to use the fact of LCT denies and we think something else should be done, that's where we're wrong. We are wrong to use the terminology approve and deny. We can agree. We can see that everything has been done so far, and this makes sense. And so we can agree that this is an avenue that makes sense at the time, but we should not be all giving the perception of approving and denying, because that means something totally different to a family. It also has held up some of the process.
Can I ask a question?
Mm-hmm.
So, because I think I've heard a lot of people believe that the family cannot move forward with the VPA until it happens. But to me, it seems like, because sometimes this is emergency,
Yeah.
shouldn't they move forward that process and they can always stop or decline? If the LCT comes up with another plan in the meantime,
Yeah.
they can then halt.
There's always a hit or miss. You know, there's always a conversation. That's why you want to discuss it.
Right.
Because maybe we didn't know what we didn't know. Maybe there's a resource that we didn't know could be explored and the family chooses to do that. Some of the problem has really come up, and Chris, you can add in or correct me if I'm wrong. You know, the ultimate is that a VPA cannot be continued on without a review by the local care team. Review needs to be expedited within 7 days.
And it would be upon the Social Services Administration to determine whether or not those parameters have been met.
Mm-hmm.
So the policy that, and hopefully everybody was able to access the Google folder that I created for this event, if you're not, let me know. The policy that there are procedures that social services must take internally. And so those are their business practices, right? And so we wouldn't want anybody at the LCT table to be kind of interpreting that for social services. Just that we're aware as LCT members that it's our duty to discuss these cases. We're going to do that. If there is not agreement, which hopefully in most cases there is agreement, but that would just be noted. And also as part of the business practices, there is some kind of documentation that DSS will seek about the outcome of that discussion at LCT. So that non-agreement would be noted, and business would just continue forward, and then DSS would make their decisions as they will.
Yeah, and if there's a non-agreement, maybe there's the belief at the LCT table that there's a particular resource that could be explored. But we want to make sure that we're not using words like should, approve, and deny. You can the team can make a recommendation that they want to put in the minutes about this could be an option for the family. Ultimately, though, it is, does the family meet the criteria that is a policy for social services? The parent in agreement has chosen that they want to move forward. And then the local department is most likely, it could be locally decided upon. Some of our local departments need a copy of the minutes, that there's a review. They have to prove that there was a review and that the review was done within 7 days. You need a quorum, whether that's by phone or in person. Nobody cares about if it's by phone or as long as you're counting who's at the table. And then ultimately what the discussion was. But we should not be saying the local care team denies the voluntary placement agreement. Number one, it gets you nowhere because they're going to move forward anyway. Number two, it doesn't make us look good because we're going against policy. So please don't put it in writing for you all that you deny it. You don't have that ability or right to deny it or approve it. You are discussing it. And you're making sure that all of the points that are necessary regarding resources, helping the family in that process, that's your goal. Ultimately, it's between the parent and the Department of Social Services. I have two questions.
Letter of medical necessity, you get rid of that, because that's not our responsibility. Like, that should not be on the parent should not have this obligation to come into the meeting with their letter. That's something else. It's part of the process, but it doesn't.
It could be part of the diagnosis, like the child is coming out of RTC and there is a letter of necessity. That's something social services.
Right, because we've had the expectation that that family has that letter before they get to their DPA. If they are just not there yet, so then we're totally off track because they haven't completed that. So we can just eliminate
As
that.
the local care team, you do not need to require that. Mental health, social services, they have their own. But if that's a part of that, then you have to worry about where are you keeping that? What are you doing with it?
Yeah, I don't keep it.
Yeah.
The DSS person keep it, but we don't. Just eliminate that from the parent's responsibility when they show up. That's a burden for them.
So we have this question for
Social services regulations.
Right,
Yeah,
but it
that they
shouldn't
do
be.
not have to have a letter of recommendation recommending RTC placement before coming to the team.
Really?
So a lot of people don't know that, and part of that is because it used to be, and there was a change. So some people have just been operating out of the process, when in actuality, the Department of Social Services regulations do not determine that that has to be made first.
And that would be the importance of why we want you to fully read on your own for your team. Every team member should be aware of what the Social Services Administration policy is.
I'm not sure our local social services is following their policy. That's what I'm trying to say.
That's okay.
In a nice way.
That's okay. And that may or may not be true.
We can always request kind of technical assistance from the Interagency Placement Committee on a case level or on the administrative level, usually in your meeting.
Thank you.
So that's cool.
Yeah.
We can do that.
Also, and I'm going to get to you. Also, so that you know, the purpose of Chris and I attending the summit about a month ago, and it was the 10th annual summit, is that they currently are in the process. There is a draft revision of the current policy that is scheduled to come out. What they were looking for was actual, and I really appreciated this, looking for feedback from those people that are directly involved in doing voluntary placements. That's why all of the VPA social workers from social services were in the room, because they were looking at updating. What we were very happy about is the updates are really more about clarification than changing the policy, because they wanted to make sure that we were getting away from perception and interpretation. So they were clarifying what their expectations were. None of the LCT stuff has changed. Gladly, in the draft revisions that we were not allowed to share with you yet, they're still worked through. They actually took into account a lot of the feedback that they were getting from the people in the room and really felt that they needed to expand upon their clarifications. But those clarifications were really to help workers and the local care team, everyone involved with the voluntary placement agreement, to make sure that we're all on the same page. So they really added some language in there. We're always usually about taking language out, make it as short as possible. Really about clarification to make it a smoother process. And also add value to the things that they are asking, why are they asking it? So you had a question over here and you got lost.
Yeah, so I'm just curious. So our LCT position is vacant, so I'm filling in. I'm the L&D coordinator, so this is a little foreign to me, like all this details. So what's the repercussion if you don't do a VPA within 7 days?
Huge deal.
So is that the time that the LCT gets the referral to the VPA, or is that from the time that social services decides they're going to move forward?
Social services. All referrals most likely for a VPA. There's a difference between a family calling you and saying, I want to get a VPA, and you saying, okay, all voluntary placement agreements must go through the Department of Social Services. Here's the contact person. You get in touch with them. Your actual VPA referrals with a time frame are going to come from the Department of Social Services, who is legally responsible to contact the local care team and identify that we have a voluntary placement agreement referral and we need an expedited process. So every LCT should have a policy, a procedure. How do you review in an expedited process? Policy and procedure for that happening. For those of you who don't, why not? And this would be why we need to know the policy. Voluntary placement agreements coming to the LCT is definitely in statute. It is a part of the law. It is part of policy. When social services provides the referral, they will let you know if it needs to be an expedited process, because it is part of the mandate that a VPA referral be reviewed by LCT within 7 days.
Yeah, that hasn't happened, and I mean, I know ignorance is an excuse, but I didn't know that, and I'm not sure that our social services follow or know that. So this is good.
That's okay if you educate them on that.
Yeah, I'm going to, because we
yeah.
have two this next week, and they've been in the queue. We haven't.
Yeah.
So thank you for that.
There could always be a discussion about voluntary placement. I mean, this could be a family that gets on the local care team agenda for review, and maybe the words voluntary placement are coming up somewhere, so this could be an education component. It is when you have a referral where you're in that process that the 7-day window must occur, and it must occur. It is in law. Yes.
Okay, so all the time when parents ask me to use VPA. So, and typically what I do then is I fill out my local care team referral, and they come to a meeting and we talk about it. Should I be saying, if you want to look at a VPA, you have to go through DSS as a person?
No, it's that twofold thing.
Okay.
Are they calling to say, I heard about a VPA?
Yeah, most
and
of the
I'm
time,
interested.
somebody from.
So then your
From hospital,
DSS
right.
representative at the local care team, when you give out the agenda, or you may want to do an alert to your social services person to say, this family is talking about requesting this. There is a difference between discussion and actual referral. That's simply what we're trying to get to. So a VPA cannot be processed without social services, but you could have a family coming to the table who's looking for options, and VPA might be one of those options.
Okay.
Nobody
You
saying,
then have to have another meeting after the referral made?
yes.
Okay. So typically what I also do is like talk about like, this is the VPA, and this is kind of what it is, and this is what that would look like. DSS gets to make that decision. So at the meeting, we could say these are all the services and we would recommend like utilizing them, but they have the ultimate decision to say, I don't want to do that, I want to apply to the VPA.
It depends on how they're coming to the table. If they're only coming to the table because they want to get a VPA, then as the coordinator, then you may want to link them directly with whoever your county's voluntary placement agreement worker is at social services. There is a worker assigned at every department. Sometimes the larger the department, the more people there may be, but there is someone assigned at every department who is the VPA specialist.
All right.
So if you have someone who only calls and only wants a VPA, you can connect them with social services, and social services can do the education for them about what that looks like. If you have a parent who says, I don't know what to do, I'm looking for whatever resources, that becomes a difference because
Right.
the VPA request to be a part of multiple options that they're looking at. If they're specifically at a point of requesting a VPA, I would move that to social services, to the person that they need to talk to.
Okay.
And then social services either work through that with them. If there is a referral, they will generate that back to you.
Okay.
And that's when the window of time happens. But that's their job, VPA's job.
That's extremely helpful.
Good. Okay. All right. We really are out of time, but we want you to have the ability to ask any questions or give us some ideas of another meeting or training that would be beneficial out of what we've talked about. You are going to get a copy of the Social Service Administration policy regarding voluntary placement agreements. You're going to get a copy of my PowerPoint. You're going to get a copy of Heidi Rashan's PowerPoint. You have your linkages to your policy analyst for scorecard. You have Chris Mealy as your policy analyst for technical assistance to the LCT. If you ever have any questions, please always feel free that, you can reach out to me. We will direct you specifically where you need to be making that communication. I also find it very helpful in, your coordinator meetings that are coming up, or in local peer team meetings that you have. Are there any other specific things that you would like to learn about? This is your opportunity to tell us. It is after 1 now. I'm going to have somebody fix that. Thank you so very much for being willing to work through your lunch and be here with us for a few more minutes. Thank you. Great question.